My name is Stephanie Kasten, and I'm a PGY2 ambulatory care resident at the William S. Middleton Veterans Hospital in Madison, Wisconsin. Ambulatory care is chronic disease state management in the outpatient setting. It's meeting with patients to discuss medication therapies, order labs, provide follow-up, and it's important to use that time to provide patient education, not only about medications, but other lifestyle modifications that can take place in order to help better manage their health conditions. Ambulatory care is also about providing referrals as needed to other specialties, and it's really a key area in which you can help provide patients with that additional information and management in order to prevent hospitalizations. I think there are a lot of key elements that you can do when you're still in school to help give you that good foundation to move forward, to have exposure to different areas of ambulatory care, and even to help decide whether or not ambulatory care is something that you want to pursue as a career. I know for myself, I really put myself out there in terms of exposing myself to different opportunities. I volunteered in a number of different areas, not only pharmacy related, but I wanted exposure in mental health, so I actually volunteered at a local homeless shelter and really got the chance to talk to people and gain understanding and appreciation for different types of patients. And I really found that through some of those opportunities, I really enjoyed just sitting down, talking to patients, learning about their stories, and I think that helped give me a sense of what I would have appreciation and satisfaction from moving forward in a career path. So just exposing yourself to different things that you might not necessarily have known that you had an interest in. I connected with professors who were very passionate about ambulatory care and had very solid practices and who were very motivated in student growth. I worked with them to build my portfolio in terms of research opportunities, poster presentations, and they helped connect me with yet other either students, recent graduates, or faculty members to help me better pursue those other opportunities that might be out there. So I tried to do a lot of different things in school to keep myself busy and to really gain a good understanding of what I thought I wanted to get myself into. My last year on rotations, I think, is what really helped solidify that with the different rotational experiences that I had. And based on some of those rotations, I then applied for a residency program. And the nice thing about ambulatory care residencies, since this is such a hot area of pharmacy at this time, ambulatory care residencies, just from 2012 to now, have doubled in the number that have been available. So it's really a growing area, and so there are a number of ambulatory care residencies. There are also a number of general practice residencies that include both the inpatient and ambulatory care aspects of pharmacy. If you're still kind of wondering whether or not this is something that you want to continue devoting time to and want to pursue as a career. So I think nowadays, with the competition that is out there with obtaining pharmacy positions, a residency would be a very wise decision in order to pursue that, to help better get ground in getting an ambulatory care position. So there's PGY1 residency programs, again, specifically just ambulatory care and general practice that include both sides of pharmacy. And then from there, I completed my PGY1 in ambulatory care. But from there, there are also PGY2 programs that are available. So that's where I currently am at in my education and exposure learning opportunities, is the PGY2 ambulatory care residency. There aren't as many of those around specifically for ambulatory care, but they do exist, and they, again, help give you a greater exposure to this type of clinical setting. I really enjoyed my diverse rotations during my 4th year of pharmacy school. I had both inpatient and ambulatory care exposure, as well as academia, and I also had the chance to go to Kenya to see pharmacy practice in that country. So from all of those experiences that I had, it was a little difficult to decide which one I wanted to go into. I had kind of an idea going in that ambulatory care was the way that I was going to go, but I was trying to keep my options open. And what I found in the other settings other than ambulatory care, I really liked the hustle and bustle of things. I liked the urgency. Really enjoyed rounding with my medical team during rounds at my inpatient sites. However, I found myself wanting to be more engaged with the patient. I felt the relationships that I had were very short-lived, a couple of days, and then they were gone. So it was satisfying to help them through this difficult time. But for me, I was left asking myself, what could have been done to prevent this from happening in the first place? And so that's where I found myself enjoying the ambulatory care setting. Having 30 minutes to talk to a patient, really diving deep into what's going on and what's helping them or not helping them manage their health conditions effectively. Building those longitudinal relationships, having patients come back every couple of weeks to see how they're doing, and seeing that progress from week to week, or seeing the impact of your changes from week to week, was just really satisfying for me. And it was almost like when you're in a new relationship and you get the butterflies in the stomach. I had that feeling about ambulatory care. And sure enough, with the different exposures, and I definitely where I ended up feeling the most comfortable and where I knew that I could really make a difference in terms of preventing hospitalizations or taking the time to give patients that education when they're in a frame of mind where they might be a little bit more receptive. I also really enjoyed my academia rotations, and I think I have a very strong interest in academia, but I found that I was able to use my interest in teaching to teach my patients. So again, it helped me really. Right now, I'm so happy with where I'm at, and I really feel satisfied being able to work in the ambulatory care setting. My roles have changed slightly from the PGY1 to the PGY2 year. As a PGY1 resident, I was able to have the exposure to a wide variety of both primary care and specialty care clinics. So I was able to spend time seeing patients for chronic disease states like diabetes, high blood pressure, hypertension, tobacco cessation. And at that time, I would run the visit, I would prepare the chart, I would interview the patient, take a step out, staff that patient with my attending pharmacist or physician, come to a plan that the attending agreed on, go back into the patient room, relay the plan to them, and help schedule follow-up. So it was a very comprehensive visit. Not only were we talking about medications, we were also discussing lifestyle modification, so diet, activity. If there was monitoring that needed to take place, we would upload glucometers and ask for blood pressure readings at home. We would also assess labs and order labs as needed. And again, also talking about the medications. And based off of the plan, providing education. So again, disease state management, referrals to nutrition or podiatry, and also talking to patients about medication side effects if new medications were started or discontinued. So that was kind of a main, that was basically the visit during the first year. And that would happen, again, either in the primary care setting or the specialty care setting. So my residency is very unique in the fact that we do have a lot of opportunities available. So we were able to be exposed to osteoporosis clinic, rheumatology, hypertension specialty, patients with diabetes on insulin pumps or U500 insulin. So having the comfort level of that primary care setting, but also having the exposure to that learning within the subspecialty. In the specialty clinics, we often staffed with attending physicians, so there was very much an interprofessional team aspect and learning opportunity that we got within those clinics. So little did I know I was going to be learning how to examine x-rays or give injections, but got all those opportunities as a first year. We also follow patients longitudinally for tobacco treatment and tobacco cessation. So that's something that, again, you get to build those relationships over time. The thing that is really nice at the VA is having a scope of practice. So as a first year, I still had to enter all my orders under my preceptor. I would still co-sign notes and run my plan by my preceptor before making anything final with the patient. But at the VA, and now within the second year, I have the opportunity to have a scope of practice. So I actually get to make all the medication adjustments, ordering the labs, everything on my own. I still co-sign my notes to a preceptor, but in that second year, I have much more autonomy to run the visits and make decisions on my own. In the second year, I still get to spend time in the primary care clinic, and I chose to specialize in this primary care setting, as well as you get to tailor the second year a little bit more. So I had the opportunity to tailor mine to academia and rheumatology. So really pursuing some of those, even though it's an ambulatory care PGY2, I am getting some of that specialty training even in this second year. So again, days are very, very busy. As a PGY2, not only are you continuing with those tobacco patients, but I also follow a panel of patients who are on warfarin or some of the oral anticoagulants or the injectables. I also follow patients for neuropathic pain management, and I also complete research either from the first year or start new research this year. And use that during some of my administrative time. And again, I've been able to have the opportunity this year to focus as well in academia. So I get a little bit of everything that I wanted in the ambulatory care setting for a residency. At the VA, we're very fortunate to have provider status, and we have scopes of practice, meaning that I can see the patient, I can make medication changes, order labs, all under my own name. Versus outside the VA, there's more of a collaborative practice agreement that you see within settings, meaning that the pharmacist will still see the patient and can adjust medications, but the orders and the agreement are under a physician's name. So they're very, very similar. I think sometimes it feels difficult to discern between the two of them. But within the VA, we do just see that much more independence with prescribing, with having that provider status. With MTM services, I feel like that's a subspecialty of ambulatory care. The nice thing about MTM services is that their opportunities for those are growing. So not only are you seeing MTM services within the clinical setting, but you also get to see them within the outpatient pharmacy setting. I think the difference between the two of them, it could come back to where you're practicing. So at the VA, I consider what I'm doing MTM, but then I get to evaluate the blood pressure readings, have those patient education discussions, but then make changes based off of my clinical experience. Whereas other facilities, MTM would include chart reviewing, assessing for appropriateness of therapy, and then making recommendations for the physician to either accept or decline. Within the outpatient setting and the community pharmacy setting, MTM is really starting to grow as well. And within that setting, you can provide the disease state education and bill for it under the outpatient setting as well, and then make those recommendations back to the physician as needed. So the MTM services themselves fall underneath the umbrella of ambulatory care. Ambulatory care is really taking off. There are a lot of hot topics that are out there right now, such as transitions of care and increasing access to care, and that's really where pharmacists can play a huge role in preventing hospital admissions from heart failure, COPD. Within ambulatory care as well, it's also the positions are growing, as you can see from the type of ambulatory care or MTM services that are opening up in other pharmacy practice sites like community pharmacy. So I definitely don't think that the demand is going to be decreasing anytime soon. If anything, again, it's increasing. And as we have more data about how pharmacists are, we already have this data, but it's growing even more about how pharmacists can impact patient education, patient satisfaction, and as providers see the utility of pharmacists in this setting, I firmly believe that demand for pharmacists within the ambulatory care setting is just going to keep going up. I think the role of the pharmacist more traditionally was seen as having that knowledge and being a good resource in some of the subspecialties of medicine. Oncology, hepatitis, some of those more challenging patients with extreme insulin resistance. But we're seeing a substantial growth with the utilization of pharmacists within the primary care setting. At the VA specifically, we have a patient-centered team model. It's an interprofessional team with one physician or a nurse practitioner, a nurse case manager, a pharmacist, and we also have clerks, nutrition, and mental health on board, but we all work together in a very patient-centered model in order to provide care. The way in which the pharmacist helps out within primary care is by seeing patients for referred conditions, patients with a diagnosis. So as it is right now, a patient maybe sees their pharmacist or their physician actually about once, twice a year, maybe a little bit more frequently if they're a little bit more complex, but that leaves a lot of time in between those visits for something to go wrong or for something to change. And that's where the pharmacist has been able to step in the primary care setting. So we will actually see those patients in the interim, continue to manage their diabetes, hypertension, thyroid, neuropathic pain, and make medication adjustments all along the way. So then when the patient does have to see their primary care provider again, some of those more chronic disease conditions are more well controlled, we would hope, which leaves time during the provider visit to focus on acute concerns, routine screenings, and new problems that might come up that would require additional lab workup or physical exam in order to provide a diagnosis. So pharmacists are really making the visits for primary care physicians and nurse practitioners and PAs a lot more efficient. And we also call patients before they see their primary care provider. So again, we're really trying to take off a lot of time that might be spent surrounding medications with the primary care provider during that first initial visit. And so again, this is increasing access to care all along, which has been something that's been of some concern within the VA recently. As pharmacists, we are also providing population management. So in essence, it's like scrubbing the panels for the primary care provider that you work with. We see what patients have A1Cs that are greater than a certain cutoff or blood pressures that are above goal, and engage those patients and attempt to engage them with a pharmacist and stop in for a visit, have a discussion a little bit further about how we can best manage those disease states. So again, that helps. It helps the facility look better with some of those outpatient national measures that should be met, as well as it makes the work of the physician or the PA really helps take a load off for them. But working within an interprofessional team to make this happen, I think has been really key, and it has been an area for which the pharmacist has really found a niche. And we've definitely at our facility have seen, increased satisfaction and just really great appreciation for what the pharmacist can do and can help with when it comes to managing medications. Oftentimes, the pharmacist will also be used as a drug information resource for a variety of things, some of which I had no exposure to prior. So really utilizing your clinical skills at this point, working with the physician, and really thinking about the patient comprehensively and how you can provide the best possible care. Again, I don't see pharmacists going anywhere in terms of their work in the primary care setting. I think the future for ambulatory care pharmacy is very bright. I think we have a lot of exciting years ahead of us. Ambulatory care is still evolving as well. So again, it's hard to say where it's going to be in a couple years, but we're really seeing the impact that pharmacists can make both in the primary care and the specialty care settings, working in those interprofessional teams to provide comprehensive patient care, to provide patient education, be that drug information resource for the physicians, medical residents, whoever might need us. We're also there to increase the access to care that sometimes can be a struggle at certain places. Pharmacists can really, based off of the comprehensive training that we've had, can run patient visits, can order labs, can perform physical examinations for patients who have a diagnosis and help them better manage their chronic disease conditions in order to prevent readmission and help patients live an overall better quality of life. I think we're going to see ambulatory care, as it already has, start to spread into community pharmacy and more so into primary care. It'll be really exciting to see where pharmacists are practicing in the next upcoming years, but I definitely think that within the ambulatory care setting, we're not going anywhere anytime soon.